Okay, the next speaker is the head of the multiple myeloma program at the University Hospital in Heidelberg. He's also the president of the German-speaking myeloma study group, where he has, since the mid-90s, built up a big group of more than 70 study centers and has been running some of the biggest trials in Europe through this study group. We always look to Germany with a bit envy with their access to drugs and reimbursement of drugs, and you're always some step ahead of us when it comes to experience with the novel drugs. So we're very looking forward to hear this talk about current practices in novel drugs in myeloma in Germany.
Yeah.
Hartmut.
Yeah, thanks for inviting me. It's a pleasure to be here. It's the second time in Oslo for me. And today I have the opportunity to present some data from Germany. You heard from our study group and also doing in Heidelberg at the myeloma center there. These are my disclosures and some words about myeloma. We have around 7,000 new cases each year in Germany. In Europe, you can see around 30,000 patients, and the myeloma patients are older and older according to the better age of the people in Europe. And you see the 5-year survival rate, it's quite different. We heard from Sonja about risk factors, and I will start with the history. This was the old days on the left side. You can see VAD, that's where drugs not very active in myeloma. It's called V vincristine, A adriamycin, and D is dexamethasone. And you can look here in red and in blue. That is the overall survival of patients in the median age of 55 years. And look here, after 2.5 years, 80% of these patients were died. Patients with deletion 70, they had a very, very, very poor prognosis. And then we had the option, together with the Hovon study group with Peter Sonnefeld, to introduce a drug. It's called bortezomib, and you can see here this is called PS341, adriamycin and dexamethasone. And look here at the red line. This is the overall survival, and you can see it's really an increase, and therefore this was the first days that we could improve the prognosis of patients with a very bad cytogenetic risk factor. Now it's another time. We have much more risk factors to include in the prognosis of patients. And you see here it's called RISS or R2-ISS. And you can see again there is some cytogenetics with 70B. You see here the LDH high. You see the translocation for 14, amplification of 1Q, and then you can really describe the prognosis of our patients. Now we have much more information about the prognosis of our patients, not only 70P. And what will be the future? We will have more and more information from the patients. This is a work that we have done with colleagues from the United States. There are different groups included, and in the end of the day, there is a possible to predict the overall survival of our patients. And you can see here in this line, this is the overall survival in the HD6 trial. This is one of our trials, including 600 patients. And you can see as the patients lived and expected, there's the same prognosis. This would be, in my future, a big step in the right direction to have information about clinical, albumin, LDH, demographic, ethnic treatment, what drugs you should use, and then we have the great opportunity to use single-cell data to better predict our patients. Then if we have these from the lab, from the molecular lab, then don't forget the imaging. Imaging, it's very important. You can see the PET-CT, and you can see here the active myeloma, and you can do it similar with MRI, and this is a special MRI technique. And then the colleagues here in Little Rock has found a big discrimination. If you have very, very large focal lesions, then the prognosis is in red very bad. And if you have lower than 3 and not so large, then the prognosis is much more better. To make the diagnosis of myeloma was some years very easy, because you see on the left the plasma cell. It's a typical cell with an eccentric nucleus. perinuclear a little bit higher. And then look here, this is the days there we are now. We have the myeloma cell, and you can see in yellow there are some antigens that we can use in the daily practice for selected myeloma patients. And if we talk about Germany, we have the option in Germany to treat every patient with an antibody. It's called CD38. You can see BCMA, you can see CS1 and other one. And I will tell you a little bit about how we can include these antigens in the treatment of myeloma patients. You can see it's not very easy to treat myeloma patients and understand the pathophysiology of these myeloma. You see the myeloma cells, you see natural killer cells, you see T cells, and all these cells work together, and it's very important to find the right dosage of especially antibodies to kill the myeloma cells and not to work against the immune system. One of the most used antigens is BCMA, and you can see in this slide on the right there is a red cell that is the myeloma cell, and you can see the BCMA is really overexpressed on myeloma cells. On the other hand, you see the B cell development here, and also some BCMA antigens are on the surface of the B cells. And if you treat myeloma patients, you will see it later, then you will have a very, very deep response with MRD negativity. And Nike showed some data that has I never seen the remission in relapsed myeloma 10 to minus 5, 10 to minus 6. This is really new days. On the other hand, if we treat patients with anti-BCMA like bispecifics or with CAR T cells, then we have a very severe immune suppression. And therefore, our patients in complete remission, they are suffering from infections. And therefore, keep in mind, it's very, very important to use antibiotic prophylaxis and also to tell with the patients about the risk to get in complete remission, MRD negativity, a very, very severe infection, and potentially to be killed from this infection. If you look at the guidelines, then the actual guidelines for Germany from the European Hematology Association from 2021. And you can see what is the first decision that we have to do. We have to decide if the patient should go to high-dose therapy or not high-dose therapy. And then you see here we have DARA VTD, as I pointed out, DARA in frontline in combination with bortezomib, with thalidomide and dexamethasone. This is accepted by the government, and also in Germany it's accepted to use DARA in combination with lenalidomide, dexamethasone, or with vincristine, melphalan, and prednisone. Standard of care in Germany is single transplantation. We have in around 20% of our patients double transplantation. Double transplantation means 2 high-dose therapies in 1.5 years. And in Germany, we use it outside of trials for patients not achieving CR after first transplantation, or they have a high-risk cytogenetic feature. If we discuss with our government about the costs in myeloma, then we keep in mind two things. Here, the Maya trial, it's comparing RD versus DARA RD, and you can see a huge difference in PFS. This is important. This is not enough for us in Germany to discuss with the government about the costs. The costs are related to overall survival. You can see the other one from the recommendation in Europe, VMP, the standard of care over many years, and then the combination DARA VMP. And this is what we need in Germany. We need an overall survival benefit, and if we can tell the government we have an overall survival benefit, then the German government will take the money and will pay for our treatment for our patients with an antibody as an example here in first-line treatment. That is based here for the patients should be treated with high-dose therapy. This is a trial Cassiopeia called. for the German, not very, very easy. On the other hand, we have the recommendation to use this treatment. Why I tell you it's not so very easy, because the history of thalidomide in Germany, it's very, very bad. Now, we had a very bad history, and some of you will knowing the name Contergan. This was a scandal in Germany, treated women with thalidomide, with Contergan, and there was a lot of trouble. What we can do to use DARA, bortezomib, thalidomide, dexamethasone in induction. We can also use DARA, bortezomib, cyclophosphamide. Cyclophosphamide is not so toxic compared to the nerves as thalidomide. And now we can use also DARA, bortezomib, lenalidomide, dexamethasone, because the price for lenalidomide, it's such going down. It's very cheap now in Germany because the license it's not related to a big company. Then we have the transplantation. Then we have DARA-VTD consolidation. And in Germany, standard of care will then be lenalidomide mono as a dosage of 10 to 15 milligram per day. This is the discussion here in overall survival. And you can see in the Cassiopeia trial, it's also a benefit in overall survival for DARA plus VTD compared to VTD alone. And therefore, the government is also paying for DARA for transplant-eligible patients in frontline therapy. The next one that we discussed, and others do the same, do we need a transplantation? You heard high-dose melphalan is toxic. We have in around 30% of the patients severe mucositis, some fever, and we lose around 1% of the patients really related to infection and death. Here was a trial from the colleagues from Italy. They compared carfilzomib, cyclophosphamide, dexamethasone with carfilzomib, lenalidomide, dexamethasone with transplantation, and here KRD without transplantation. And you see here on this side in red, the winner of this three-arm trial. It's clear KRD followed by transplantation in terms of PFS. Therefore, our recommendation in Germany, it's clearly up to the age of 70. Please use the old drug melphalan, 200 microgram, followed by peripheral blood stem cells. What are we doing to improve the quality of treatment in Germany? I will present three trials from the different study groups. This is a study group headed by Hermann Einzele in Würzburg. And the last trial of the DSMM was KRD, carfilzomib, lenalidomide, dexamethasone, comparing to elotuzumab. Elotuzumab is also an antibody against an antigen of the myeloma cells, and you see here induction, stem cell mobilization, induction, melphalan as standard of care, and then consolidation with ELO KRD versus KRD alone. And then you can see here in the blue arm, this is the standard of care for Germany, lenalidomide until progression disease, and you see here ELO plus LENA as an experimental arm. What have they found? The Würzburg group has found that the addition to elotuzumab to KRD is improving MRD negativity. That is 10 to minus 5. That means around one clonal cell in 100,000 normal cells. It's the sensitivity of this test. And you can see there's a high difference in terms of MRD negativity in this trial. There are other trials not have the same results. Therefore, it's good to have more trials with one question to really get the information. Every trial will have the same result, or we have different results, and then we have to discuss what could be the reason. The study group GMMG has done also an ELO trial, not supportive to use ELO in primary disease. We have a second trial here. You can see RVD, standard of care, as a recommendation in Germany. And then we use an antibody against CD38. It's called isatuximab. We have done a longer induction treatment, 18 weeks, transplantation, no consolidation, standard of care, lenalidomide, experimental arm ESA plus lenalidomide, and you see similar to the DSMM in this trial with a CD38 antibody, the MRD negativity is much more higher in the arm with the antibody. What is the conclusion at this time? We need PFS data, and we will have these data in December of this year. The first analysis of PFS in December last year showed not a significant improvement of the PFS, and therefore our study group is working very hard to get the PFS data in this year and hopefully present a positive result in next year. Katja Weisel from Hamburg has done a GMMG trial, it's called CONCEPT, and she makes a decision in our study group not to treat every patient with the same treatment. He has used a high-risk definition with ISS, that means low albumin or high beta-2. Then here cytogenetic positivity for different cytogenetic abnormalities, and then every patient would be treated very, very intensive with ESA, KRD, carfilzomib, lenalidomide, dexamethasone, 8 cycles. Then hydrotherapy for the patients transplant eligible, and for patients not transplant eligible, a long-term here 8 cycles. Then consolidation, maintenance, and you see the maintenance is with 3 drugs. This is it's a good combination, and as you heard before, for really high-risk patients, in our view, we need a long-term treatment in contrast to the patients with good cytogenetic risks. These are published for 2 weeks in the GCO, the PFS, and we have also in this trial MRD negativity 10 to minus 5, and one of the good predictors for PFS is a sustained MRD negativity. What we do in the future? Hopefully for all our patients in Germany, RVD or KRD will be the standard of care as induction. We will give all our patients an CD34 antibody, daratumumab or isatuximab. It's good to have 2 drugs, not only 1 drug. Then we go forward. This should be the standard of care in 2024 in Germany. And then you heard from the German view, lenalidomide is the standard of care as maintenance. And we want to use in the ongoing trial, in the next trial, iberdomide. Iberdomide should be less toxic than lenalidomide, and the other one is that iberdomide should be more active than lenalidomide. We not compare iberdomide with lenalidomide. The company is doing this step, and hopefully they will be successful. Then it's the right trial. If the company is not successful, then we have to discuss the results. What is another way together with the group from Würzburg, we are thinking it's time to bring immune therapy in frontline therapy, not only an antibody. We want to test, and we are doing testing teclistamab. It's a bispecific antibody. Mark Raab and Leo Rasche from our centers are responsible for this trial. And you can see here is a 4-drug combination, teclistamab, bispecific antibody in combination with daratumumab, lenalidomide, dexamethasone. And that would be successful. Then we will go to the 5-drug combination. That could be very toxic. Therefore, what is the message after 10 patients treated in this direction? We have in every patient MRD negativity 10 to minus 5. It's very nice. On the other hand, we have some side effects, severe infections, and therefore the group make the decision to reduce the teclistamab per time, and hopefully the reduction of the toxicity will be in the same direction. Not working, we hope that 10 to minus 5 will be also negative in most of all patients. This is for the maintenance or consolidation. You see teclistamab, it's also a part of this new direction, and we hope to combine 2 antibodies, one against BCMA and one against CD38, and then with low dose lenalidomide and therefore to have not so much toxicity. We heard here from the Scandinavian countries, they have a very good registry and have an overall overview about your patients here in this area. As you heard, the prognosis of myeloma patients is better and better. Therefore, we started to start with a registry also in Germany. We bring the long-term data from the different trials from the GMMG in this registry. The questions in terms of remission are similar as in the trials. For the first 3 remissions, we use the original data to get the original data to discuss with the government. And we need such data independently from the companies to bring more information about the long-term survival in myeloma and what is the sequence of the treatment outside of the trial. You can see that is our country, that is what the DSMM is doing, that is the GMMG is doing. If we work together, hopefully, and we not only hopefully, we have more and more patients in trials, and therefore we want to bring these data for our patients and to discuss with the government about the availability of the different drugs. What the colleagues are doing in the lab, they look on the clones. They are in the myeloma disease. You know, we have not only one myeloma clone, we have different myeloma clones in the patients, and therefore the analysis of these different clones, it's important. This is a composition pre-treatment, and this is a composition after the treatment. This is in refractory myeloma, and you can see there's a difference in the characteristics of the different clones, and that could be in the future helpful to have the best decisions in terms of which kind of drug I need. Then this is in German language. That's around 190 pages, how you should diagnose and treat the patients. That is based on Cochrane analysis, and therefore for the German colleagues, it's a good possibility to look in this book or look in the internet. It's for free, and this is from February 2022, and we will have at the end of this year a new version of the recommendations for diagnostic approaches and the treatment in multiple myeloma. If I'm here in Norway, I want to say to my colleagues in Germany, thank you so much for your work. The study group, it's meet 2 times per year. You see this is here in Heidelberg. It's in the fall 2023, and it's around 70 up to 100 colleagues. They discuss what is the best next trial, what is the toxicity, what is the research in terms of MAD and other things. And here a picture from my hometown, from Heidelberg with the old castle. And if you have time to come to Heidelberg, you are invited. And it's a nice place, and not only in myeloma, also for the visitors. Thank you so much for your attention.
Okay, we start with questions, and Fredrik was first.
Thank you, Hartmut.
Yeah, the camera wants to see you.
So, could you just briefly say what is available in your country when it comes to immunotherapies, teclistamab, talquetamab, bidecel, cilta-cel? What's the situation now?
Yeah. We have a good situation, is the first answer. What means good in this situation? We have the opportunity after the 3rd relapse to use CAR T cells from both companies. And the government is paying at this time for both CAR T cell products. It's not sure if that would be in 2024 the same situation, because the government is only accepting prospective randomized phase 3 trials. They are not accepting comparison between phase 2 trial and real world data. They're saying this is a bias. Therefore, the price is going down for the CAR T cells, and the companies, they're saying it's not a good signal from the...
But now both are approved based on phase 3 trials.
Yeah, this is in discussion in Germany. The discussion in between the companies and the government needs more than 1 year, because the companies in Germany have to give the original data to an institute. It's called in Germany Institute for Quality in Medicine, and they get the original data from every patient, and then they make their own analysis of the trials, and this is not every time the same result. And therefore, the discussion for the randomized trials is ongoing. It's not finished. And the discussions based on phase 2 trials, it was positive, and now the government is not supporting these data from 2022 in Germany. What is the situation with bispecifics? We have the opportunity to use 2 bispecifics, both from Janssen, takelamab and tequiltamab. The insurances have to pay at this time. There was around a time of around 9 months the insurances had not to pay, because the price from the company and what they want to give from the government view was a big difference, and therefore over 9 months we have a free access program from the company supported for our patients, and now there is an agreement between the government and the company, and since September, since last month, the insurances have to pay. At the end of the day, we have both CAR T cells. After the 3rd relapse, we have two bispecifics for our patients, also after 3rd relapse, and then it's a discussion ongoing with approval from the other company with a bispecific, and at this time we have not a price for this, and if we have not a price, then they are not paying.
And can you just say something about the experience of having these drugs available? What's your experience with having these drugs available in your hospital?
Yeah, I'm very happy about this question. I'm in the myeloma field since 1991. And in the early days, the median survival was around 3 to 4 years. And now I have patients never seen with so long life. Patients with high LDH, with terrible cytogenetic feature, if they are treated with anti-BCMA, they achieve sustained remission. Sustained means 12, 24 months with good life quality. I'm so happy about that. And now we have patients, they failed to get a remission with anti-BCMA, and there are new drugs with other targets, and we have trials in Germany, and also we can use one of these new drugs outside of trials, and therefore I have some patients, they fail to anti-BCMA and now in remission with the other antibody, and the quality is also not bad, I would say. And this is a difference in myeloma treatment I have seen in the first 20 years of my work in myeloma, never. And now the patients really in good life quality, as Sonia pointed out. And the other hand, it was terrible if 10 years before you have relapsed myeloma patient, LDH high, bad cytogenetics, you can have done what you want. You had a remission for 3 months, and then that was all. Yeah, I'm really happy to be part of this development, and as we heard from Nikhil, these drugs will become in the frontline, and you have seen from the German view, we are doing also some research to have a balance between total remission, as Bart was saying to us, MRD negativity in imaging, and on the other hand, we have heard about infection, life quality, and to find a good balance between response and life quality, and hopefully a lower rate of severe infection. That would be a good way.
Thanks.
We also in Germany had made the decision to analyze life quality in our trials, and that could be also a good idea to harmonize these activities. And I heard here from Sonia in a very clear fashion, life quality, it's very important. And if you have a life for 10, 15 years, the life quality is much more important as you have only some months.